Hello, thanks for joining. I'm Alex Abbott. I'm a primary care sports medicine physician practicing at Stanford. Today I'll be reviewing some of the most important and the most up-to-date information that providers should be aware of in order to take care of athletes as patients, specifically when we're dealing with something called the athlete triad or REDS. Other than my clinical practice and my work in athlete performance, I have no relevant financial relationships, and this presentation has no commercial bias. I'll start by getting us on the same page with some background information about REDS and Triad, and then we'll talk about the underlying mechanisms and the most recent and exciting literature on the topic. We'll apply some information to help providers consider frameworks for diagnosing, recognizing, managing patients with concern for REDS or Triad, including some common reasons for blind spots or bias. After the talk, I'm hoping that you will feel confident to understand the triad or REDS and how to treat it, especially as it relates to nutrition, bone health, and multidisciplinary care. This talk will also serve as a refresher on a commonly misdiagnosis, and I'm hoping that this memorable guidance will give you the knowledge to be a more sensitive and objective provider in your clinic. So we'll start with some definitions. REDS stands for Relative Energy Deficiency in Sport, and that term is currently sort of in a competition with the use of the terms female athlete triad and male athlete triad. The ICD code and the answer choice on an endocrine exam or another board exam would be functional hypothalamic oligo or amenorrhea. And the triad of factors is low energy availability, which can be intentional or unintentional, consequent reproductive repression, and or menstrual irregularity. And then the last is decreased bone mineral density. There's been decades of research behind this concept of the athlete triad and robust consensus about the interrelation of these factors. In 2014, the International Olympic Committee, the IOC, was tasked with updating their position statement on the female athlete triad. They noticed that there seemed to be more associated consequences of low energy availability than just bone health and menstrual irregularities, and that the consequences also seemed to apply to male athletes as well. The bone protective effect of estradiole's inhibition of osteoclasts is really well described, but the mechanisms for the detrimental and more systemic physiologic effects of the triad or REDS are the subject of ongoing research. In addition, epidemiological studies are limited by the evolution and the definition of the way that we talk about the triad and REDS. A large and recent study by Gallant et al. Combined 59 studies in over 6,000 athletes in total and characterized a rate of 45% of these athletes demonstrating low energy availability and 63% with REDS. Low energy availability in athletes in this study were commonly associated with many different aspects of decreased performance, including training response, endurance, coordination, explosive power, and agility measures. The athletes with low energy availability were also more likely to require absence from training related to illness. Prior to this meta-analysis, the IOC estimated the prevalence of REDS in athletes globally in a wide range between 15 to 80%. We definitely need more large studies and more sport-specific studies to determine which type of athletes bring the average close to 40 to 60% for low energy availability and REDS, which overall is a significant proportion of athletes in general. Despite the high prevalence, it's easy to miss in clinic. The symptoms are diffuse, but also easy to silo or section into subspecialist consults or divided workups. I think about my extensive education in medical school about lupus. I had professors that called it the great mimicker disease. This sort of has systemic symptoms all over the body, and patients who have this can be segmented into different subspecialist care without a unifying diagnosis. REDS can be sort of analogous in this way that the different symptoms can be broad and siloed, but early disease looks a little bit softer. And the analogy sort of breaks when you think about the fact that for lupus, the early signs tend to be more distressing for the patient than often they are for REDS patients. REDS isn't really represented well in residency curriculums for primary care, and it's also pretty difficult to test on board exams because there's not specific biomarkers to test on, buzzwords, specific chief complaints with this high on the differential as your diagnosis. And then once providers do start learning about the Triad and REDS for their clinical practice, it's often with this kind of poster patient in mind that we think about for the female athlete Triad, being like lean, female, elite athlete, especially runners, dancers, and gymnasts. These risk factors are definitely there, but often this phenomena isn't really considered on the differential diagnosis if they don't fit into that poster patient presentation. Athletes also don't often present with concerns for REDS the way that they might come into your clinic for other musculoskeletal concerns. They come in suggesting things like shin splints or fractures or things like this and do the work for you. And some athletes even go in the other direction. We think about especially those in malignant gymnast cultures where I've heard of patients saying that they're encouraged by their loss of periods as a sign of intense training. So they're not necessarily advocating for you to go looking for it, and the symptoms are a little bit broad and vague sometimes. When we consider the clinician's bias a little bit more, if you have a patient who comes in with a low or normal BMI, they are young and healthy, they endorse a regimented exercise routine, that can sound really reassuring as a history when so many patients with obesity are being managed for concerns for long-term metabolic syndrome in your clinics. In family medicine and internal medicine especially, that's probably the majority of what patients are being taken care of for in their regular health maintenance exams. So you might have a sense of relief when someone comes in and says that they work out 7 days a week. A visit also might be 20 minutes long. The athlete might dismiss the provider's concern about a missed period or 3 and want to talk about something else. And you also tend to need longitudinal histories to be put together, but our healthcare system is increasingly fragmented. People are seeking care online for specific types of problems. They're coming to their primary care providers only as needed for specific sick visits. And they are self-referring to subspecialists often. So this creates essentially a lot of Swiss cheese holes that can force an error and miss REDS or Triad diagnosis. Finally, when we think about the patients who present most commonly with this, so young adults and adolescents, they often add significant new layers of psychosocial factors to your history taking, especially when parents are involved as well. So you sort of have things moving against you in the direction of digging for something else. So earlier we defined REDS for viewers who had not heard of it, but some viewers have heard me probably using REDS and Triad interchangeably through this talk and wondered, why are we not choosing one term or the other? Just before this talk is created, the Female Athlete Triad Coalition, which has created update statements for male and female athlete triad through the last few decades, released their update statement. And in a mood that makes me sort of feel like my parents are fighting again, they reiterate the use of the triad as the appropriate way to diagnose this, not using the term REDS. The reason why they're sort of alternative school of thought compared to the IOC, who is using REDS as the vernacular. The the Triad Coalition is in favor of really focusing on where the evidence is the most robust. This is low energy availability, reproductive repression, and impaired bone health. That's where the evidence quality is the highest. And they're questioning the quality of the evidence that supports the previous diagram that I showed for REDS, which is that sort of radial hub and spoke diagram that has all of these other sort of associations that aren't as solid in the evidence as the three that we talk about for Triad. The coalition also has concerns about confounding variables, especially related to overtraining, and that's separate as an etiology from low energy availability. I'll talk a little bit more about overtraining syndrome later. Overall, we just need more research to concretely associate low energy availability with those other spokes on the wheel of REDS before the coalition and the clinical community will likely agree together that we should abandon the use of one or the other terms or come up with a new term. We also need more independent variable study to differentiate lack of energy as an etiology versus overtraining. Regardless of which term is used, low energy availability represents the primary etiology. Low energy availability represents a deficit of calories in to calories out. Some literature has described a possibly clinically significant threshold of 30 calories per kilogram of fat-free mass per day in any patient, but it's difficult to assess measures of energy availability like this in clinical settings. Calorie deficit is the mainstay of many successful weight loss and body recomposition plans, but prolonged and/or severe deficits start to contribute to problematic low energy availability. Many athletes will report motivations to decrease weight for physical performance and power in more power-based sports like cycling and rowing are the ones that come to mind first. They often report motivation to improve their aesthetic physique for sports, or they just unintentionally have severe or too prolonged low energy availability because of their high training volume and poor fueling habits. Some athletes with the Triad and REDS have diagnosable eating disorders, and so we start thinking about intentional low energy availability and multidisciplinary ways to mitigate that. For athletes with body composition or weight loss as a secondary goal to overall performance, the performance detriments of prolonged low energy availability actually paradoxically sort of prove counterproductive. After weeks in a deficit state, hormone changes reflect a shift that suggests down-regulating non-essential functions for survival. This is a theoretical hypothesis in terms of why this happens, but the consistent associations that we see with low energy availability and decreased hormone levels in the setting of adrenal upregulation and increased cortisol suggests that mechanism. Depending on an athlete's weight, this process of feedback and the hypothalamic pituitary gonadal axis changes can start and continue while BMI is still remaining normal. In 2023, the IOC's update included a clinical assessment tool to help screen for REDS and stratify risk. There's also increasing evidence to suggest an additional or concurrent etiology to low energy availability with low carbohydrate availability. Finally, as mentioned previously, recent studies are focused on the overlaps between Triad or REDS and overtraining syndrome, which I'll talk about later. Given that there's only 3 types of fuel sources, carbs, proteins, and fats, decreasing energy availability globally is bound to decrease your carbohydrate intake. Studies that are designed to evaluate the effects of low energy availability as an intervention concurrently tend to decrease athletes' carbohydrate intake by between 25 and 60% historically. But these studies are typically designed as short-term interventions. Athletes in real life often try to decrease carb intake with elimination as the goal, and they do so for periods that are defined by their goals, not by a study design. So if we haven't achieved a weight or a physique or a watt to power ratio, watt to kilogram ratio that we're looking for, we might continue the duration irrespective of a set program. The short-term studies demonstrate associations with low carb availability and bone formation impairment, increased IL-6, which is associated with immune response, and increased hepcidin, which is associated with iron metabolism. Sometimes short-term sacrifices related to carbohydrate intake are made intentionally in supervised training programs with the goal of stressing carb metabolism in preparation for competition. This supercompensation effect with short-term detrimental effects are not what most athletes are doing on their own. This graphic from the Olympic Committee sport dietitians demonstrates more objective examples of macronutrient manipulation based on training goals and fuel needs. Fueling can be fine-tuned. We can periodize by training intensity, competition timing, and with refeeding periods to mitigate long-term effects of low energy and or low carbohydrate availability. Again, this is not what most athletes are doing who purport low carb, keto, carnivore diets, fasting practices, weight cut periods, clean eating, etc. In addition to the systemic health effects of REDs that may present vaguely in clinic, an athlete's mental health indicators can also present as the initial symptoms, as the predictive factors, or as profiling clues of REDs if you're attuned to the type of athlete who's susceptible. We often associate perfectionist tendencies, anxiety, disordered eating, obsessive tracking of food and exercise, and high cognitive function with athletes who engage in problematic low energy availability. This list of psychosocial factors came with the Triad Coalition's update in 2025 as well. We think about susceptible athletes being associated with a high level of specialization, which is when a single sport is trained at the expense of sports sampling or participation in other sports. We think about aesthetic sports, high pressure sports where selection and leveling are factors, and the degree of athlete identity in the patient, to name a few. These mental health factors and some of the physiologic factors represent significant overlapping components between the triad or REDS and something called overtraining syndrome. Overtraining syndrome essentially occurs at the late stage of non-functional overreaching. So an athlete goes from a level of high exercise strain where they're seeing performance gains to a point where we describe non-functional overreaching, where someone's working hard but not seeing performance gains because of inadequate recovery, and then to a point where overreaching also starts to become associated with systemic symptoms that we also see in REDS, especially fatigue, increased illness frequency, and mood dysregulation like anxiety and depression. Overtraining syndrome and REDS, they're both continuing to evolve semantically, but it seems most objective at this time to characterize overtraining syndrome related to training excess as the etiology, and REDS or triad as being with low energy availability as the primary etiology. In clinic, recognizing REDS doesn't need to rely on a gestalt or profiling a patient just looking for somebody who's seems to be a perfectionist who's exercise obsessed. It doesn't have to be this abstract way. There's clues in the history that might include recurrent bone stress injury, GI complaints, fatigue, mood dysfunction. These are very common chief complaints, and REDS or triad is part of your differential for all of these things. On exam, it's important to differentiate healthy athlete bradycardia versus concerning bradycardia related to low energy availability. We think about orthostatic monitoring, so checking vagal tone with orthostatic vitals can help reassure or improve your assessment of an athlete with bradycardia. Monitoring growth charts, as we do for well checks anyway, also helps to determine if the objective findings are supporting REDS or Triad in your assessment, especially for seeing decreases in the percentile over time. Finally, the use of validated screening tools can help dramatically decrease the sensitivity and specificity for detecting these patients in clinic. Once you're starting to recognize your suspicion for low energy availability, whether you think it's intentional or unintentional, triaging the acute care patients is the first step. This list isn't exhaustive of concerning symptoms, but it helps to triage patients who might warrant inpatient refeeding. These are a BMI of 75% or less of the median for sex and age, which is not to be confused with the 75th percentile BMI. I provided an example on this slide to help differentiate the significant difference between those two measurements. We also think about electrolyte disturbances, which often involve potassium, sodium, and phosphorus for these patients. EKG abnormalities, especially prolonged QT and bradycardia. Hypotension, we think about less than 90/45, significant orthostatic vitals, and then if someone's failed outpatient treatment, has medical complications of malnutrition, or if they have any other conditions that would impede successful outpatient treatment and monitoring. Keeping things objective, REDS patients may warrant different types of workups, treatment, and monitoring based on their risk status. So the IOC consensus group designed clinical assessment tools recently updated to the CAT-2. Don't be overwhelmed by this. We're going to walk through it together. There's 4 risk categories: red, orange, yellow, and green. Based on how many primary indicators and secondary indicators apply to the patient, the risk is stratified accordingly. Starting with severe primary indicators, the most significant risk factors, these are primary amenorrhea, which is when someone has never had their first period. We get concerned about that starting at age 15. The second one is prolonged secondary amenorrhea. So secondary amenorrhea meant that somebody had menstrual periods, but then they stopped, and then the prolonged qualifier makes this a severe indicator when periods have stopped for 6 months or longer. So these 2 severe primary indicators count each as 2 primary indicators when you're tallying up your points for the risk. The primary indicators in the middle include secondary amenorrhea, but without that prolonged component. So we had initially regular periods and now we don't, and that's for 3 months or more. And then we also have history of high-risk bone stress injury. So the different sites of bone stress injuries are the way that we define high or low-risk sites. So some examples of high-risk sites, but not exhaustive list, include the navicular foot. We think about the anterior tibia, femoral neck stress fractures, just to name a few. Another risk factor in the primary indicators is if somebody's had 2 BSIs or bone stress injuries anywhere in the body, so 2 in the past 2 years, or if they had to lose 6 months or more of training related to bone stress injuries. Moving down the list, we think about negative deviations on the growth chart, a high score on the eating disorder assessments, low testosterone, thyroid labs, low bone mineral density marked by osteopenia on your DEXA. And then when we move to the secondary indicators, which carry less weight than the primary ones, these include oligomenorrhea, which is 8 or fewer periods in a year, a history of any bone stress injury in the past 2 years, anxiety or depression, and hypercholesterolemia. I highlighted the risk factors in purple, which are all the risk factors that can be assessed with just a history and physical. So none of these require labs or imaging. So you can see most of the indicators in the REDS CAT-2 are highlighted in purple, and so that I think makes this a pretty useful screening tool. For patients that are scoring at yellow, which is your mild risk or higher, you would consider expanding your workup to improve your risk stratification and the diagnostic specificity after that positive screen. Based on the risk stratification, the treatment, monitoring, and sport clearance recommendations from the IOC can help guide your frequency of follow-up, whether you need to consult multidisciplinary providers, and whether clearance is restricted. An athlete's ongoing monitoring, your assessment of their adherence to the treatment plan, and then the consequential clearance that you're basing on that repeat assessment can often benefit from the use of a treatment contract like this one. This really helps athletes feel like they are aware and they have transparency with their providers. They don't feel like they can argue or feel blindsided that things have changed or that conditions are not being transparent with them about their clearance status. And it can help them feel like they are not just sort of controlled or without agency, and that they are a stakeholder in their own health instead of reliant on all the external stakeholders in their lives. It also can empower athletes to feel accountable for the outcomes of their own clearance when they know sort of what the requirements are to maintain their either relative clearance or progression towards full clearance. This list of risk factors has some support in the literature, but not enough for the IOC to include it as scorable indicators for the REDS CAT2. Future research making the associations more compelling for risk stratification will be the next step for these outcomes in the literature. When we're expanding the workup, the labs that can help assess low energy availability and bone health include the CBC, CMP, lipid panel, iron studies, thyroid studies, reproductive hormone studies, and vitamin D. If expanding the bone health workup is indicated, say in the case of a bone stress injury, we might include PTH, FOS, ALK-Phos, and magnesium to help rule out organic causes for decreased bone mineral density. For imaging, MRIs are commonly used for athletes with musculoskeletal complaints that are concerning for bone stress injuries. DEXA scans are less common, but the IOC recommends its use for patients with yellow or higher assessed REDS risk. In my practice, I consider ordering DEXAs if it's likely to change management, which more often the diagnoses have been made without the need of this study, and the risk stratification is not likely to change with the positive or negative indication of that bone mineral density indicator. If the IOC REDS CAT2 framework is a welcome screening tool for you, I've condensed it and converted it to clinic-ready tools. On the left is just a copied, you can just copy paste this as a epic dot phrase so that you can use it in your notes and fill it out quickly with the patient. And then on the right, if you prefer printable questionnaires, you can look to these QR codes to access these for free. Without objectivity, the common pitfalls for providers include just scrutinizing the obvious cases, trusting the dismissal of athletes who don't think that they need help or that reproductive repression is fine. When we delay or we miss diagnoses of REDS or Triad, that can result in cementation of unhealthy athlete behaviors that is more difficult to undo, as well as greater difficulty reversing the outcomes that are detrimental to the athlete's health and their performance. When we're treating these athletes, our goals are to restore energy availability and then correct the underlying causes for its presence initially. We also want to set athletes up with a multidisciplinary team so that we can support them in many aspects to prevent relapse. Dietitians and providers can help athletes with understanding their intake needs, some fueling strategies, and any supplementation needs if those apply. Calcium, vitamin D, and iron are all really important for optimizing performance and injury prevention, and these three nutrients in particular are often lacking in typical diets, even when energy availability is adequate. Sports psychology, adolescent medicine, physical therapy, and the primary care providers themselves can all work together to guide athletes for responsible exercise progression. This can be more emphatic of an injury prevention or injury rehab, especially in the setting of bone stress injuries or other injuries. And it may be focused more on psychology and safety when we think about patients with eating disorders or disordered eating behaviors. The BSI progression of exercise is out of the scope for this talk, but I would direct you to another talk that I've done that features the Stanford protocol. You can find that on this same YouTube channel. A sort of basic rule that we cite and I've heard cited in many clinics is the 10% rule, which is known actually pretty colloquially. We think about the injury risk increasing if your exercise volume exceeds a progression of greater than 10% per week. This is applied best to running mileage. So if an athlete's running 10 miles per week and wants to increase that, we might consider adding 1 mile per week to one of the runs that they're doing to up titrate that volume really slowly and to keep that risk for injury really low. To contrast with this, many athletes sort of have a base that they just consider their normal or tolerable running mileage per week. And then when they realize a new goal for mileage or have a competition coming up or a race, or they start a new cross country season and their coach has something else in mind for their weekly mileage, they just increase it at whatever rate they are needing to based on external factors instead of following a program with gradual progressions. The 10% rule is also being fine-tuned in the literature. The use of the acute to chronic workload ratio is tending to gather more favor in the sports medicine community. This describes the volume of exercise in the current week as a ratio over the volume of exercise in the last month. So to give a really sort of dramatic example, you think about if your acute workload is the first week of January and you're a resolutioner with a new gym subscription, and then you make that the numerator of a ratio over the month-long sort of average of what you've been doing through the middle through end of December, and your acute to chronic workload ratio is probably going to be pretty high in that scenario. The study I cited here, Torsdahl et al., is pretty recent. They talked about the acute to chronic workload ratio and used marathon runners to evaluate if there's a number in that ratio that seems to be associated with injury. And they did draw an association with the threshold of 1.5 or higher as being associated with injury in these runners. We definitely need more research about the 10% rule, about acute to chronic workload ratios, sport-specific research, male versus female athlete research, lots of different directions to go into this. But some of these numbers, 10% per week, 1.5 acute to chronic, those can give a little bit of a barometer in terms of your guidance for patients and improving the objectivity and legitimacy of your recommendations. As mentioned before, providers like me in primary care sports medicine, dietitians, mental performance counselors, and sports psychologists, physical therapists, athletic trainers, and the other parts of the athlete support systems are all crucial components of every athlete's care. Endocrinology as a consult can be really valuable for patients that have osteopenia, and recent updates in this field are evolving rapidly, especially in the way of treatments for REDS or Triad. Following athletes with these diagnoses often occurs annually when adolescents need their pre-participation physical exams. But if you've recognized low energy availability or concern for it in an athlete, they often benefit from 3 to 6 month follow-up, even if it's just for care coordination for these patients who often need multidisciplinary care. As sort of a post-test, I'll wrap up with this thought experiment. So let's say a patient presents to your clinic with foot pain and you order an MRI and diagnose their bone stress injury, in this case, a low-risk site that doesn't need surgery. Their recent health maintenance labs, you look back and you see that they had low vitamin D and calcium, and they're not on any kind of supplementation. So this may be a contributing factor to their injury. Think about what you would do next. Would you expand the workup? Would you ask more questions? Let's imagine you ask them what kind of sports they play and you check on their height and weight, and they're an indoor athlete in a low impact sport with a normal BMI. They didn't play sports in the season prior to this injury and they sort of went from 0 to 100. You might put together that their vitamin D deficiency, their preference for indoor exercise is attributable to that, their bone stress injury related to their ramp up in their activity and being active last season may be the culprits. So now let's look to the middle where we swap out just one of these characteristics and now we make them an elite dancer still with a normal BMI. Does the fact that now they're an elite dancer, so participating year round in one of these poster patient sports, does that make you more uncomfortable with not expanding the workup? Now, let's imagine that this elite dancer has a low BMI. Does that change anything for you? What if the patient was a male athlete? Does that make you less nervous? What if the site ended up needing surgery because it was a navicular foot instead of metatarsal and they had a really severe bone stress injury? In reality, every patient that comes into your clinic for any complaint can be profiled. You can look at kind of their demographics, how they present, what they say to you at the very beginning of the visits to decide what your assessment and what kind of things you're going after. But the difference between implicit bias and risk factor stratification depends on the evidence basis for the profile that you're building on your patient and what you do with that information. So some of the major takeaways, whether you call this Triad or REDS, it's going to depend on future research and the future consensus statements. But whatever you call it, it's common. It's not just about menstruation. It can limit performance. It can be life-threatening, but it's preventable and reversible. Multidisciplinary care is really important for improving outcomes when we're guiding athletes with nutrition, their mood and attitudes, and their exercise progression in particular. And then whether you're using the REDS CAT2 or other screening tools, the use of a specific screening tool can help decrease the chance that bias or time constraints force miss or delayed diagnoses. If you want to read more for yourself about the Triad or REDS, these are some of the most up-to-date references. Thanks again for your interest and viewership. Check out the other videos on this channel or send me a message if you have any inquiries.